Hi, this is Serena Sun, founder and director of Breaking Taboo. Welcome to our audio video podcast. Today I am here with Dr. Ryan Vidrine, who is an interventional psychiatrist, and he specializes in OCD and anxiety disorders. So that's a lot.
Thanks for having me.
Yeah. Thank you so much for being a part of this. And I'm so excited to chat with you today, Ryan, because I remember during our phone call, we just went on and on about all sorts of different topics that you do. One very interesting about Ryan that we're going to get into, Dr. Ryan, is, is that he does some very cutting edge, modern, advanced interventional psychiatry treatments. So you do brain stimulation, right? And also with ketamine, you also do treatments with the drug ketamine, which otherwise known as Special K. So that's what I know about that is that it's an animal tranquilizer, and also kids sometimes use it recreationally. However, I do know that in recent advancements of psychiatry, it's being used in therapy treatments. So that is so fascinating, very, very fascinating. I would love to learn a little bit more about that, just jumping straight in. There's so much to talk about. So
Yeah. I mean, we can go wherever you want. So with a kind of newer branch of psychiatry, interventional psychiatry, where we're trying to look at not just doing stuff all over the whole body, but trying to zero into specific brain targets and circuits. And so one of the things we do is transcranial magnetic stimulation, where we use magnets to specifically target specific circuits in the brain. And that's approved for depression as well as OCD. We treat with that as well.
What do you mean by magnets on the brain?
So we use magnetic coils, and they're about the same strength as an MRI. And there's different versions. So there's one that comes in a helmet. There's one that sort of looks like a paddle that sits against the head. But we focus them over the parts of the brain where the circuits lie that we know are involved in either depression or OCD. And depending on how we stimulate, we can activate certain circuits or we can decrease the activity in certain circuits.
Okay, so is that somewhat like when we see in pictures, people having like the little patches in the wires that they put on their heads,
So that's usually EEG. So that's usually kind of like, think of an EKG for the heart, where you're just recording activity. So that's usually recording brain activity, which some people are looking at. Can you use that to then decide the best way to treat with brain stimulation? So that may be involved more regularly down the road.
Okay, so what does this one look like?
So it kind of looks like you're sitting in a dentist chair. And again, there's a couple different machines. One of them has a coil that's built into a helmet. So you kind of wear a helmet, and you don't see much, but you can feel the stimulation on your scalp. So we give magnetic pulses, and what it feels like is something kind of tapping on your head. And there's another version that's just a kind of figure-8 shaped coil that rests over the spot on the head. So it's kind of just like a metal arm that sits like this.
How interesting. Wow. And with the metal arm one, the figure-8 one, can clients feel it on their head as well?
Yeah, so when the magnet goes off, when we release the magnetic field, it actually makes your scalp muscle contract really quickly, and which is not something you're used to feeling, and it feels like something's tapping really hard on the head. So it's usually kind of weird or kind of uncomfortable, but not super painful. And the more you do it, just like you don't feel your shirt on your skin at the end of the day, your scalp sort of desensitizes. So each time you get a treatment, it gets easier and easier and easier.
Interesting. And this is mainly used for OCD and anxiety, you said, right?
So it's been actually FDA approved for depression first for like the last 10 years. So it's actually been around for a while.
Is this the one, I think I've heard of it, but I mean, there's so many new brainwave simulation treatments now. I don't know if this is the one, but I have heard of a few different ones. One of them being they sit on a dentist chair, and then it's kind of like they get put in a trance or like a hypnotic state, but there's something over their brains. And from what I've heard, it's actually quite relaxing, and it works very well for depression. I don't know. I don't know if it's the
Not
same.
sure what that is. There's no trances or hypnotic states with the TMS. Everyone's awake. In fact, we want you awake. There's no anesthesia or anything like that, though. So it's outpatient. You kind of come into the office. You can drive to and from treatment without any problem. We have a lot of students that come on breaks between classes, that kind of thing.
Oh, wow. Wow.
Yeah. So
And
it's
then,
been around for like 10 years, and then OCD was recently approved to treat as well in the last couple of years since 2018. So
okay.
that's kind of a newer indication for it.
And what happens when the client's sitting there with this thing on their head?
So historically, nothing really. They sort of sit there and they get the treatment, and I talk to clients about it's sort of like going to the gym for your brain. So
Mm,
it's a treatment you have to do a lot. So you come in Monday through Friday. It's about 20 minutes, so it's pretty quick. But you come in for 4 to 6 weeks of doing this, and so it doesn't work. You're not going to notice a whole lot after one treatment or two treatments. But as you come in, we slowly kind of strengthen those pathways or strengthen those circuits, and people start to feel kind of subtle improvements week to week. So
wow.
any one session is kind of, they just come in, they sit in the chair, our technician will place the coil, and they get the treatment, and they just kind of feel that tapping on the scalp throughout the treatment.
And that's it?
That's pretty
They
much it.
just they just sit there. They don't have to, no assignments. They don't have to do anything.
So that's a good question. So from the beginning, we just, if all they do is sit there and they get the treatment, it seems to help. But the newest kind of wave of this, and where a lot of the research is going, is can we help even more? Are there ways to enhance it? And so we know, for instance, with OCD treatment, if we activate some of the fears that the patient has, some of their obsessions. So if they are scared of contamination fears, for instance, if we actually have them imagine touching really dirty things, or we may actually have them touch something dirty in the room, activating those circuits may make the treatment work even better. And so for
Wow.
our OCD patients, we're doing some little mini behavioral therapy exercises, exposure therapy exercises with the treatment. With depression, there's a lot of questions of, could you do some cognitive behavioral therapy at the same time, or mindfulness exercises at the same time? So most of us think that actually that stuff probably makes a difference, what state your brain is in, or what it's doing at the time of treatment. And I think that's kind of where a lot of the research is going right now.
Oh, interesting. That's fascinating.
Yeah.
Wow. Okay. So I think that's just further proof that a lot of these symptoms that people experience, obviously it stems from the brain. It's not necessarily what people think of as a mind over matter per se.
Mm-hmm, mm-hmm.
All the time, especially if you can literally like tune up. It sounds like you're literally tuning up the brain,
Well,
right?
yeah, one way you can think of it is, when you don't have depression or anxiety and you get stuck in an unhelpful thought pattern, right? You might just snap out of it. And that's kind of what we tell each other to do.
Mhm.
If you're stuck in depression or anxiety, the mechanism that your brain uses to snap out of it, that's the disorder. It's not working right. And
Mm-hmm.
so we think that these different networks or different circuits involved in that process, if we can kind of strengthen them or get them back in balance, if you will, we're kind of helping the person to be able to snap out of it again, or kind of get themselves unstuck a bit.
Yeah, because it's like a spiral. When someone starts to think about
Right.
something, whether it's OCD, anxiety, or depression, sometimes what happens is once they start to think about it, it's like almost compulsive. They think about it again, and they think about it
Mm-hmm.
more and more, and then it's like they get stuck in this pattern of thinking about it, and it just gets worse and worse, OCD or depression. So that's fascinating. So this is almost like a way to unhook them from the spiral type thing, right?
Yeah, and I tell patients, we, kind of that same gym model. We're strengthening the parts of the brain that resist, or if it's an OCD, resist doing the compulsions, or help you to hear the obsessive or intrusive thought but ignore it, or kind of notice it but stay present and move on. That's the parts of the brain that we're trying to kind of strengthen.
Hmm. Yeah, that's fascinating because I know that a lot of mindfulness exercises focus on the same thing, or
Yep.
cognitive behavioral therapy, for example. Like that's exactly what it
Yeah.
focuses on, is the thought patterns, and how to switch the thought patterns, and mindfulness as well, or meditation or whatever. So this is just like an
Totally.
added tool.
A really cool place we're going is, we know behavioral therapy things work. we know these circuits are involved. Can we pair them? Can we make both therapies more effective by combining them? And maybe something that would have taken you 6 weeks at the beginning, now you can get better in 3 weeks or something like that, right? So
Yeah,
that's, I think that's where
absolutely.
we're going as a film.
Absolutely. The only thing that I'd be familiar with as far as what I call fast tracking, is playing around with our subconscious thoughts,
Mm.
which is, falls into hypnotherapy or, right before you go to sleep or right when you
Mhm.
wake up, like those, the states of your brain that you're in are the most susceptible for you to do things such as affirmations or, hypnotherapy work,
Mhm.
meditational work to switch your thought pattern. So that's what I do. That's like, but again, like I said, it's work. It's like self-development work. It's like, okay, I
Yeah,
gotta
well,
do this. And
yeah,
if
that's
I could
kind of
supercharge
the,
it with this, maybe I could just be like a superhero. That'd be
maybe, yeah.
awesome.
Yeah, yeah, yeah. I mean, you're touching on too, like that's kind of the premise behind some of the newer research into psychedelic medicine and into that ketamine that you brought up.
Yeah.
There's
What,
using ketamine as like a, oh, go ahead, sorry.
oh, I was gonna ask. So what is that called? The ketamine, is it, it's just called ketamine
So
therapy or?
ketamine is the drug,
Mm-hmm.
which has been around forever. We use it in little kids. We use it as anesthetics. It's used in pain often.
Oh, okay. I wasn't aware of that. I always just associated it with animal
Yeah, and then
tranquilizers.
it is a street drug, so it is kind of a known party drug as well. But that's been around, and then it's there's various forms. So you can get it delivered by IV, you can inject it. It can be compounded into an oral pill or a lozenge, and then the newest version is called S-ketamine, which is a nasal spray, and that's what our
Hmm.
practice is currently using. And
That
so
is so interesting.
yeah, there's the drug itself when it works for someone tends to work really rapidly, and that's where it's gotten a lot of steam in psychiatry. So can you relieve depression symptoms or suicidal thoughts in a really rapid way? Um, and it does seem to help a lot of people. It doesn't last super long, so unfortunately, on average, it's a couple of weeks of relief. Um,
Oh. Is that
but
because the ketamine's in your system for a couple weeks, or why is
we're not
that?
sure. That's still being worked out exactly how it works or exactly why, for some people it's shorter or longer than others.
But it's approved. It's
It got FDA approved for depression and for recently suicidal thoughts
hmm.
specifically. So,
So what
and
happens?
that's just giving someone the drug and they feel this kind of relief. The other way of using it is ketamine assisted therapy.
Hmm.
And the idea is kind of what you were saying is it puts you into a different kind of consciousness or mental state that you may not be able to access on your own or very hard to get to. Because ketamine is a dissociative drug, so it kind of can take you out of your head in a way or out of your body
Hmm.
in a way. And so there's a lot of people using ketamine to assist in therapy and looking at it as, can you have a new perspective shift or a new way of thinking about your problem that will help you to do better, right? And so maybe those effects that you get out of that could be more long lasting than a couple of weeks.
So is this how the therapy goes? Basically, someone goes in to the therapist's office or psychiatrist or whoever's qualified to perform the ketamine treatment, and
Mm-hmm.
they spray their nasal spray with ketamine, or
Yeah,
take
so
in
there's
some
a nasal
form.
spray or
Okay,
again,
or
yeah,
pills, or I don't know how
injections.
injections.
So with
Okay.
the injections and the IV form of ketamine, you can get up to higher doses, which have a more dissociative effect, and so that tends to
Hmm.
be, I think, more preferable in people doing therapy.
Okay. And then they lay down on a chair or something like
Yeah, so
like
we
stereotypical
use
almost, yeah, therapy
totally. Well,
sessions.
so we have comfy kind of either couches or chairs. So we really believe in kind of the same model that's used in plant medicine and psychedelic medicine. I don't know if you know the term set and setting at all, but it's the idea that if you're working with the unconscious states or these kind of altered level of conscious states, that the set and the setting are really, really important. So what are the kind of intentions of you taking this medication
Oh,
and going
okay,
through
right.
therapy?
Mm-hmm.
And what is the actual setting that you're in? So
Mm-hmm.
with these medications, you can hear of bad trips or this or that. In the studies where it's paired with a trained therapist
Mm-hmm.
and where the setting is really controlled, really warm, really supportive and safe, there are almost no bad experiences. They're
Oh, that's
hard
great.
experiences. Some people go through really hard stuff, But usually at the end of it, they say, I'm still glad that I did that, or I'm glad that I figured that out or had that experience.
Wow, how interesting. So they get somewhere comfy, they lay down or sit down on a comfy
Yeah.
chair. There's a therapist there, and the therapist kind of walks them through like what? Like repressed memories
It can,
or
not necessarily repressed memories. It's
feelings?
different
Okay.
person to person. Again, part of the idea is we don't know. We kind of trust the unconscious state and the altered state a bit, that the person will be able to kind of figure this out with
Hmm.
themselves. Just having someone there to support them, to keep them feeling safe, to help them along the way. So it's really different from person to person. The idea is just trying to help them get unstuck a little bit.
Oh,
And
interesting.
so it may look very different with someone who's had lifelong depression versus someone with a lot of trauma or someone with OCD. It tends to be a less directive, a more supportive kind of let their mind take them where they need to go kind of thing.
Okay, okay. So that would probably be the difference of the major difference between, well, besides the fact that it's a drug, but this and hypnotherapy, because a lot of what
Mm-hmm.
you said really reminds me of hypnotherapy,
Mm-hmm.
which is, the therapist spends one time putting the patient into like a hypnotic state where they're, kind of like in between and they're in a trance mode or their subconscious is more malleable. And then the
Mm-hmm.
therapist walks them through certain things, such as repressed memories, which is why I
Mm-hmm.
ask, because it's very common for that. I always say there's so much power in our subconscious, there's so
Yeah,
much
yeah.
untapped power that yeah, it's just we can tap into in certain ways, like hypnotherapy, and now it sounds like a ketamine. So interesting. By the way, we are by no means telling anyone to self-medicate, okay? Like, we just got to put that
Correct.
out there. Yeah, don't go
Yeah,
off
a
and
lot of
start
these
doing
are
this.
still not legal. The places where they're done and in trials, it's with trained people who prescribe this, or it's part of a trial and there's training involved. So definitely not the same just doing this on your own by yourself.
Exactly, exactly. Just got to put that out there. um, but my school of thought, and this is just my personal opinion, but I've always kind of been a little hesitant to support things that make people rely or dependent on any type of substance.
Mm-hmm.
um, you know, uh, because just like you said with ketamine, you said that if they just do it, if they just take it, the results may only last a couple weeks and then they're back to the same state as before. They still have the same problem. So it kind of doesn't, it's not really a solution. It just kind of sounds like a crutch or, just a temporary
Maybe,
solution.
yeah. It's different person to person. So, for some people, it's enough to buy them time to get engaged in therapy, maybe, or,
That's true.
um, or it kind of unsticks them, and they can kind of think of problems in a little bit different way. And so, for maybe those people, the drug wears off, but the
Mhm.
benefits have maybe still been there.
That's true. That's a very good point. Yeah, especially if someone's in a suicidal state, like every
Right.
second matters, every minute matters. So
But I agree.
fascinating.
The dependence piece. I mean, I would agree with you. We have I kind of have a way of talking with patients around whatever it is, because you could do this with anything, whether it's a substance, marijuana, prescribed benzodiazepines, or sex or food or whatever it is. Kind of a question often around marijuana of, are you using this right now to escape and not feel
Mm,
something, or are you using it to enhance maybe sometime with your friends or a partner and it's a fun time, but it's not every single day all the time, right? And that's kind
mm.
of a helpful guide that.
Yeah, and I think that line gets blurred a lot.
Yeah.
And I think
Yeah.
it's one of those things where, like, yeah, it's pretty easy to just use it all the time if
Mm-hmm.
it's readily available, like, but yeah, I mean, I don't know. I don't, let's not get so into that one because that's not your specialty, right? Let's get into some of the other things that is your specialty, which is OCD and anxiety. I know that
Cool.
you have a lot of thoughts and experiences around that. So one very interesting subject that we were chatting about over the phone before this, that I want to bring up is you were telling me about certain types of OCD that you
Yeah.
treat. Some of them very interesting and quite unique, and a couple of them I've never heard about, such as you mentioned something called sexual
Yeah.
OCD, right? Yeah. So what is sexual OCD?
So I this is one of the reasons I like working with OCD, is that it's always interesting. We have a few different types that I can mention, but really OCD can be about anything in the world. I've heard pretty much everything you can imagine at this
Give
point.
us some examples, just some examples
Yeah,
that
well,
most
so some
people
really,
don't
really
think of.
common ones. The media always does the hand washing and the contamination fears, but that's probably not the most common thing I see. So OCD tends to go after things that are kind of taboo or embarrassing, or that's why sex, I think, comes up a lot for people. But sexual orientation OCD is a really common one. So this is someone who's not trying to, decipher their actual orientation. In reality, they may think they are, but it's usually someone who's very secure, has lived their life as one, particular sexual orientation, and starts to have thoughts that maybe they were wrong, and how can they be so sure, and they need to find out for sure, and they need to prove that it's one way or the other. Mom who was like in her 30s and married with kids and saw an attractive woman get on a bus and started having thoughts of, why did I think she's attractive? Could I have been wrong? What kind of woman in her 30s doesn't know? And starts going back to her, friendships as a 12-year-old, and was that really a friendship, or could it have been something more? And it's really sad when it's destroying their life that way, but it's bizarre.
Actually, I was actually just gonna say, I don't think it's that bizarre. That's why I'm laughing, is because I actually feel like it's so relatable, because you don't know, especially in our day and age of the LGBTQ community is gaining a lot of momentum and a lot of respect, and people are coming out.
It's not bizarre to have a thought, right? We all have like thoughts all the time about everything. The patients will tell you it's bizarre because I've never thought about this before, or it's bizarre because I'm pretty sure I'm straight, right? But what if I'm not? What if I'm wrong? How will I tell that to my husband?
Right.
So
I think it's the fear aspect. So like when it becomes a compulsion, but what I'm saying, the relatability, is that I feel like everyone at some point in their life has questioned their sexuality, and even more so now. Even more so now, I don't know, I just find it very common, especially for young kids, to it's like cool now to be gender fluid. So fascinating that it can actually be an actual OCD disorder.
Yeah, and I think it's important, the amount of suffering that these people are going through is immense, right? And so you definitely see, I think, throughout society and pop culture and videos and stuff, of things kind of being thrown around more casually or colloquially, or people kind of testing out things or wanting to be like hip, and I think with these people,
hip is a good word.
with these people, like, it's not that, right? It's
an actual fear.
I mean, so the international, this just reminds me, the International OCD Foundation just has run a big campaign around, OCD is not an adjective, trying to get people to stop saying things like, oh, I'm a little OCD, or, my touch of OCD, because those are quirks, those are preferences. But for these people with actual OCD, it's debilitating often.
I remember learning in my very first psychology class back in high school, the class that got me into psychology, Psych AP or Psych 101 AP or something. And him saying, I remember when I first learned about OCD, our professors, or our teacher, said that everyone has a bit of OCD. Like, I remember him saying that, like, everyone's got a bit of OCD. Like, if you're checking, really interesting. Well, I don't know. Psychology research changes too. The terms change, science changes. So it could have been something like back in the day.
Well, there's a biological reason for sure why we want to maybe have rituals, right? So rituals have been around for a long time. There are biological reasons to be pregnant women about to give birth. Actually, there's a spike in OCD diagnoses around that, the kind of nesting thing or protecting young, right? So it's built into us to be able to do that, but then in these disorders, it sort of goes off the rails and kind of gets hijacked.
Well, it's functional versus functional impairing, I guess. Well, okay, so you talked about sexual orientation or OCD. You just touched upon pregnancy OCD. What is that?
Yep, that's really common. Just so a lot of both, it can be fathers as well, but I've seen it more in pregnant moms or moms who just gave birth. Just thoughts like, what if I throw my baby out the window, or they're cutting up things for dinner, and what if I stab my baby, or what, you can imagine. And then moms then are like, oh my God, what kind of mom thinks those kind of things? I must be awful. I must, and it's this cycle of shame and then anxiety and fear and then shame again. And these people, these are not people that do this stuff. It's getting that thought. And then again, new parents, it's pretty common to have some dark thoughts. You're not sleeping, you're really stressed, it's hard work, people don't understand it. And so everyone probably, you can relate, have had a thought of like, oh, I could strangle them, or I could do this, or I could, it doesn't mean anything. You don't think past it. It's more of an expression. But with OCD, those thoughts can get stuck and kind of keep going. And then the more you think it or feel it, the more you start to question your own character and this thing. So it's, these people come in really scared and feeling really bad. And then,
but they don't ever act on it, right? Like that's a different thing. Or do they? Or does it cause them sometimes
to? I mean, we rarely say never, but for the sake of, working with OCD, yeah, basically these people don't ever do this stuff. They're the least likely in some ways because they're so terrified of doing it, right? And because it's really, so the other one that kind of goes along that we see all the time is intrusive thoughts and obsessions about pedophilia. So I've had babysitters who come in, a 22-year-old girl who during bath time had the thought of like, what if I touched them in the wrong spot? Or what if that was inappropriate? Or maybe they were texting with their boyfriend at the same time and he said something kind of risque and she was feeling a little flirtatious or turned on, and then said, oh my God, but I was washing a kid. And like, what if that means that I'm also attracted to, they don't make sense. They're not rational, but it kind of gets stuck in their head. And again, people are terrified to talk about this.
How common is that? How common is the pedophilia OCD?
It's one of the most common ones. I hear it all the time. And people that don't work with OCD a lot don't necessarily know that. And so I've also had people come to me and say, almost wait the full visit before they even bring it up, because I've been told, my last provider told me that if I say this again, they're going to have to call Child Protective Services and that they're going to have to report me. And which is just heartbreaking because they're scared to even seek help. And these are people that don't do this stuff. They're the least likely because the simple idea is so terrifying to them. It's not something where they're sitting there, getting aroused and enjoying it. It's a lot of suffering. I don't know that we know why it happens. I would say in general that almost all of the thoughts that turn into obsessions are intrusive thoughts for patients. They're normal thoughts that most of us might quickly have for a split second and probably never remember, or doesn't really jar us in any way, right? Example people use all the time is like, when someone says, imagine your parents having sex, we're like, no, let's not do that. Move on, right?
Right.
With someone OCD, things like that get stuck and they can't get it out. And so,
why does it get stuck?
There are some genetic commonalities in OCD. There's some brain circuit dysfunction that we know for different patients. Their brain may make more obsessions and kind of hard to move on. The parts of the brain that I was talking about earlier where they resist that or they move on or they snap out of it for whatever reason don't quite work like they should. And so
interesting.
Yeah.
Is that, do you think that's more of like a brain functionality or a mindset type thing?
So it's a brain problem. I mean, OCD is probably one of the most well-known of the disorders in terms of brain circuitry compared to some others. So,
if you don't,
oh, sorry.
Oh no, I was going to say, so if you're not genetically predisposed, then you probably can have these thoughts all day long and it wouldn't be an issue. And
and not everyone who is genetically disposed gets it. So we know there's, it may be high stress environments. It may be really, really rigid households or something may predispose you. It could be some traumatic experience that kind of colors you and tips you over. So you got to have probably a genetic predisposition. And then
I was going to say, I kind of feel like so many people have this genetic predisposition though, because OCD is so common. I'm just saying, like, OCD is so common, or like even the more functionally, like even like little spurts of it. Like, for example, one of the things that I do that is kind of OCD is like, if I know I have to get up for an important meeting, I have to check my alarm clock like 1,000 times, and before I can fall asleep. Or like if I go away on vacation, I have to go,
Totally.
sometimes I have to go back to my lock before I like walk to
Yeah.
the end of the hallway and then
So
like check my stoves, but then I'm fine after I do
yeah.
that.
So
But
what we would say about that is we would try to get you to not say that OCD part of it, because that what you're doing there is, and this is what everyone does, right? This is why they had a whole campaign about it, because it's so common. Is
Interesting.
that's an adaptive response. So your brain knows something important is coming up. It wants to prepare. It's thinking about what could go wrong, and it's leading to you doing some useful things, taking some preparation and this and that, right? OCD is, 500 times what you just described in a way that's not adaptive and not helpful, and they end
You
up
mean
missing the
diagnosed?
vacation.
Yeah,
What's up?
the
Well, and
diagnosed OCD. Like,
yeah, yeah.
I'm
I
just saying
mean,
because you're
because OCD
directly
isn't OCD unless it's really diagnosed as it was.
just FYI, you're directly contradicting my last podcast
Yeah,
with
I heard that.
OCD. Yeah, so I
Yeah,
just find it very interesting. And of course, like I said earlier, like psychology is a very big field, and there's always new advancements. And I don't know if you're talking about functionally impairing versus not, but or just like the fact that we shouldn't be calling things OCD unless they are diagnosed, like the DSM definition of OCD, which I
yeah. I
can
mean,
understand
I
too.
think functional impairment's a better way of thinking about it. The DSM is always changing and not
Right,
really trying to
exactly.
use
Yeah.
the gold standard of things. But yeah, I mean, the difference between I did a bunch of things to be proactive and make sure my vacation went great, right?
Uh-huh.
Versus these people don't get to vacation because they can't stop checking the locks and they miss their flight, right? I mean, it's just
Right.
like a vastly different normal worrying, normal preparation, normal healthy checking to be safe and proactive to disordered or functionally
Right.
impairing, like you said.
And that's when they have to get therapy for it, obviously.
Yeah,
Right.
and the reason people are talking about that so much, that distinction, is because what they're finding is it's already really hard for patients to get that diagnosis and get right treatment. And what happens is, they might mention this to a
Oh,
teacher or a friend, and they imagine what they hear everyone say, right? Like, oh, well, I have OCD and so do you, and we all have a little bit of it. And then what happens is they never actually get routed to get help, or it's written
interesting.
off, or it's imagined to not be that big of a
Interesting.
deal.
On the other side of the coin, though, on the other hand, to play devil's advocate a little bit, I deal with this a lot with depression, right? With breaking taboo, depression stuff, with people that come to us with depression, diagnosed or not diagnosed. And, depression is one of those also where it's like, like, if you have depression, like, does it have to be diagnosed? Does it have to be, how functionally impairing? Like, the scale of functionally impairing is extremely wide. But is it okay to tell someone who is feeling depressed that no, you're not actually depressed because you don't fit into the DSM, definition of depressed?
Yeah,
Because I've been there. Like, when I was depressed back in high school, I never got treatment for it because my parents didn't believe in therapy.
right.
I would beg them, and
Yeah. I
unfortunately, I
mean, so
never went.
I agree and disagree with you. Like, I think we're saying a little bit of two separate things. So I think the DSM has huge numbers of problems. It's an area I'm actually really interested in the way that we classify or pathologize things,
Uh-huh.
many of which may be an adaptive response or a fairly normal thing, versus something like schizophrenia and OCD are very clearly brain circuit problems.
Mm-hmm.
So I think just because you haven't gone into a doctor's office and them gave you a DSM diagnosis doesn't mean you don't have that.
Right.
But you probably don't have it if it's not causing dysfunction.
Right,
And
but that's
dysfunction
that's
is
the part I'm talking
broad,
about.
right?
Yeah, how much dysfunction? Is it
Yeah.
dysfunctional enough for you to go get help? But then that's the part, again, that's also um, difficult to say, because when do people get help? Just like you were saying, people might have OCD, but they're afraid to go get help for it, or maybe they
Yeah.
don't even know they have
Yeah.
OCD because of the stigma, or just because they don't know, or lack of knowledge, whatever.
Yeah.
Same thing with what we deal with all the time with breaking taboo and depression,
Yeah.
right?
Yeah.
It's like people might have depression, but they're not getting help for it. They might just think they're sad. They might just
Yeah.
think like, oh, I'll get over it, or why can't I get over it, or this is
Yeah.
not a real problem, or whatever. But on the other hand, there could also be like it works both ways. There could also be people who are sad, who are trying to avoid the diagnosis of depression, and therefore they don't go in, and the sadness becomes worse, or whatever. Or there might be people thinking like, oh, I'm not sad enough to, you know, really be thinking I'm depressed, but they really should be getting help for it. So I don't know. I don't know about the I don't know. That's an interesting thing that's happening with the OCD, and how many, like, what we should call OCD, because I'm just flipping that and just saying, instead of OCD, let's replace it with the word depression. You know, how would I feel? How would the, you know, how would people who are depressed feel about that? And I don't know. I don't have an answer, but it's
Yeah,
interesting to
it's
think about.
interesting, and it's controversial in the field. I would think of those two differently for a couple of reasons, but like one there's a discussion happening within psychiatry around diagnosis, right? And so there's one group that we really clearly, we can study it and you can see it, and you can, you know, florid bipolar disorder with florid mania, schizophrenia, really severe OCD. There's really clearly, like, what's happening there is not supposed to happen. And we know, we're able to see sort of brain circuit dysfunction, that kind of thing. Then we have the biggest class, which is like generalized anxiety, depression, right? Which those labels get thrown around all over the place for all kinds of things, many of which may be actually adaptive, your body kind of telling you something, right? So we know there's a lot of stuff, whether it's people in, you know, losing a loved one, in bad relationships, a society that's very inequitable, being in a job you hate, being in a city that you're actually not that adapted to live in, right? Or, you know, not being part of nature. There's all kinds of things that, the analogy I've heard that you may appreciate is like a broken bone. So if your leg broke, right, our body releases all this stuff that makes us feel pain and swelling, and it doesn't feel good, and it's inconvenient.
Right.
We would never just give you pain meds and send you on your way without casting the bone or fixing it. So there's this push to think about, you know, are we actually just sort of slapping on a diagnosis and trying to make people more comfortable with what they're feeling, rather than thinking about these things as telling us something, and trying to get at the core of it. So could we do more community intervention, connecting people, you know, face-to-face interaction?
Absolutely. No, I would definitely have to agree with that, because a diagnosis, also, so many people are misdiagnosed all the time, because there's not, I mean, I always say psychology is a relatively new field. We know so much about psychology. We've gone so far in it, but still the field of studying the brain and psychiatry, you know, is neurology, whatever, is still pretty new. So what happens sometimes is people end up with a diagnosis, but they don't really actually fit in that, like, that may or may not be what they are, but it's the closest that the therapist can get, I guess, that they write on the form, you know, for insurance purposes.
Fitting it for a system, exactly. Yeah, it's
right.
not really putting the person at the forefront of that. It's saying this is what we have to do because the way the system got.
It's like a label, a label for insurance purposes. And I think that the thing with that is that's when you have to figure out, like, the insurance side of it, and what's happening there with that system is, like, why do they have to have a diagnosis in order to be able to provide insurance? I mean, can't people just go to therapists because they're, like, not feeling very well, or they just want to talk to someone? I mean,
I think most psychiatrists and therapists would 100% agree with this, and I don't know anyone that likes the way the system works.
Good to know. Interesting. It sounds like there's a potential for some revolution there.
We hope, yeah. I mean, I think everyone kind of sees that. It's what we have to work in, and at the end, we're still trying to help people, even though, I mean, I tell people all the time, I have to put this label. Here's what I think is really we need to work on, or here's what I think is really, you know, going wrong.
Got it. That's good that you tell your clients that, though. It's very, because otherwise they could walk away with a false, like, something, you know, they're thinking that there's something that they're not, and living their whole lives like that, you know. But no, it's good. There definitely are very intuitive psychiatrists and therapists out there. I actually want to ask you something. Because we were talking about you did watch the last podcast I had with the OCD therapist, right? Okay. Do you remember the part where she kind of diagnoses me, where we're talking about, so basically for our audience out there, what happened with me was this is a full story. So I was seeing a therapist slash life coach. Like basically it's just someone that I wanted to talk to on a weekly basis and dump a bunch of my shit on, right? But then during that time, I had a very close friend of mine jump off a building and kill himself. And it was very traumatic for me, extremely traumatic for me. And then out of nowhere, that's actually part of the reason why Breaking Taboo was started. Although I've lost multiple friends, but you know, he definitely drove that. And then out of nowhere, I started getting these thoughts of these weird thoughts. Like I couldn't go on the train. I got afraid of heights. I'm still afraid of heights to this day. And I have no idea why. I've always been not afraid of heights and proud of it. You know, I've always been the person like walking in high places, or, you know, I went skydiving. I wasn't even scared when I went skydiving. And then out of nowhere, it was difficult for me to take the train, and I had to bring someone with me to the subway station or just stand in the middle of the, you know, the station, because I don't know, I just had these really weird, intrusive, like spontaneous thoughts of like, what if I jumped? What if I jumped? Because, and I knew it was because my friend jumped, and but just out of nowhere, it just, you know, that thought was put in my brain. I was traumatized. That thought was put in my brain. And then I started thinking that. So in the podcast anyway, she said that was OCD. But going back to my therapist slash life coach at the time, when I told her about this and I told her that it was scaring me and these thoughts were scaring me, I was really scared. I didn't know where it was coming from. And I was like, I don't want to, you know, like commit suicide, but like I think of jumping, and it's really weird. And she actually said that I can no longer treat you. And she thought that I was suicidal, and she thought that I was depressed and suicidal. And I always thought that there was something else there. And then I spoke to the OCD therapist in the last podcast episode, and she actually said that it was OCD.
The only way I would maybe say it different is that's definitely intrusive thoughts. And it's definitely, it sounds like maybe at times some obsessional thinking, but certainly intrusive thoughts.
Right.
In terms of, you know, you could label that as OCD. If it's right after something like the death of a friend, you might label it as acute stress disorder.
Oh.
We see intrusive thoughts in really severe depression, and we see intrusive thoughts in PTSD, right? And so this is again where our labels really fail us, I think. It would be a red flag to certainly think about asking you a whole bunch of questions about other areas of your life. At the end of the day, the way we would probably help treat you would be probably very much in line with how we treat someone with OCD.
Right.
You know?
The part that I felt was missing though is the compulsion. I was like, where's the compulsion? What is so?
So compulsions can be mental. So, you know, if every time you had a thought about jumping in front of a train, you started thinking of all the reasons why you would never actually do it, or you started touching yourself in a certain way to make the thoughts go away, even though it made no sense. That could sometimes be considered a compulsion, just a mental ritual. But the other thing we'll see a lot is avoidance. And some people would call avoidance a compulsion, or because you're avoiding, you never sort of get to the compulsion. So if you stopped going to the train, or I guess maybe a compulsion would be bringing someone along with you for reassurance. That could be.
Or standing in the middle.
Yep, that would be avoidance / compulsion. So
okay.
Again, I think we'd be careful about saying, oh yeah, you have OCD, but we'd say, yeah, this is a fear response. This is intrusive thoughts. You know, where your life coach, you know, missed it was exactly what you said. This is usually what we call ego dystonic. So I have the thought, even though it's not something I want to do. I see this a lot with my OCD patients who have intrusive thoughts of self-harm, and they get thrown in the hospital, or people won't want to work with them, or they get overly scared. And again, they're scared of what if I do it, they don't want to do it, or, you know, you have to figure that out, obviously. They can't have both, but yeah.
Yeah. Well, like I said during that episode too, what I did was I got hypnotherapy for it, which really helped, and it was actually very fast and easy. I
Cool.
remember the process. It was she had me basically she put me in a trance state, and then she just had me imagine this like a safe place. What's my favorite place that's safe? Put it in this box, and then imagine the train tracks and put it in this box, and then we merged the boxes together like slowly together. So my subconscious basically merged it together, and then the dangerous place became the safe place. And and then she had me rethink basically of the trains and make it
Yeah.
like a safe place, and to change the colors. In your brain, you change the colors
Yeah.
of it and everything. So it was very fascinating,
Yeah.
actually, for me
Well,
to learn too.
I think what's nice with what you're doing with the podcast like this is that really basic education for a lot for anxiety disorders in general, and certainly OCD and some of these others, can go such a long way. So a lot of people like yourself or others will have an intrusive thought, whether or not it's depression or PTSD or OCD, but they have an intrusive thought
Mm-hmm.
and they say, "Oh shit, what did that mean?" What kind of person has that kind of thought? What does that
Right.
mean, right? And just saying to a patient, "Yeah, intrusive thoughts are super common. They don't always mean a disorder, but they're super common. They happen in
About
all different
anything.
ways." Yeah, about anything: sex, religion, harm.
But then
Um,
I thought you said that OCD. Okay, okay, wait. So
yeah,
intrusive thoughts are common. It
yeah,
happens to everyone. Everyone has them. And
they can,
random
yeah,
intrusive thoughts, like for example, um, uh, like train tracks are dangerous, or
yeah.
whatever. Like intrusive thoughts, like don't go in front of a train, or something like
Yeah,
that, right?
or
But
imagining
then,
your best friend naked, right?
oh,
What?
right, right.
Why did I think that? Like,
Right, imagining that you're about to run naked. But then the OCD comes when you start to avoid it, or you feel compelled to do something about it, or when
when
does that
you the
become
OCD comes
OCD?
when it becomes so distressing that it actually gets in the way of life, and that is
Oh, okay.
intentionally broad because that could mean a whole bunch of things.
Right, because
But
I was just thinking I don't have to take the train, I can just take the Uber. It doesn't really get in the way of
yeah,
life.
yeah, if you go about your life generally and you're pretty much doing anything and everything that you want to do and need to do, then you're probably just in the range of normal that, had an intrusive thought or had an experience that was really intense or this or that.
Mhm. Well, I
When
really
we're
didn't like
talking
it though.
to, yeah,
I
yeah,
really
well,
didn't like the
and
thought. I really
you
wanted to
got it,
get
you
rid of it.
intervened, right? So you
Hmm.
got it, had you kept going and had you started to change behaviors more and more because of it, that's
Mm.
how you grow an anxiety or grow an OCD or whatnot. So
Yes. Well,
when I see the
I've always
patients
believed in
there,
like facing your fears, or
yeah,
just I was just like, what the heck is going on?
exactly, yeah, yeah. Just helping them know that this is a normal phenomenon, and sometimes it's irrational, sometimes it's scary, sometimes it's bizarre, but it doesn't have to. It's not reality, right? So
Hmm.
the scary things make us change our behaviors, but I always tell patients, right, like, what if you imagined winning the lottery tomorrow? Just because you imagined it, you wouldn't go quit your job and buy a Ferrari, right? The thought, the fantasy, the whatever it is in our head isn't reality, but we pay attention a lot more when it's negative or scary.
Ah, yes, yes. Our brains are fear driven. Definitely. Yeah. I mean, doesn't that suck that our brains
Yeah.
naturally like tend to hold on to things that are negative, or
It
fear is
suffers
like,
now. I mean, it was clearly adaptive for a long time, probably helped us survive in some ways, but
oh
yeah,
yeah. Yeah, yeah, because we have to
if
do
you're in a
like
jungle.
right, but it's like we have to do like 100 times the work for the good stuff, and then like it's like one bad thing,
Yeah,
one
yeah,
scary thing can just derail that. So
yeah,
it's a
yeah.
lot of
Our
work,
brains were
self
meant to
development.
survive, not so much maybe thrive.
Right. Interesting. Yeah, I like that. Our brains are meant to survive, not so much to thrive. I
I
really
mean,
like
that's
that.
like you're saying. That's the harder work for sure.
Yeah, yeah. So, okay, so what are some of the more bizarre OCDs that you deal with?
Yeah. One of the it's maybe not as one of the most bizarre ones. Well, so there's things that make absolutely no sense at all, right? So if I don't move my body in a particular position, then something terrible or bad will happen to a family member. They might die, right? And so I've seen people who are essentially freeze in
Oh,
certain things, or they get stuck and they have to go through a mental ritual of maybe they're retracing every step they took in their head, or maybe they are praying in their head, or so again, those things aren't connected in any way, right? But
has it
it's
ever
bizarre.
happened in your office where
Mm-hmm.
someone has just frozen?
Absolutely, yes.
Interesting. Interesting.
So there's that. There's just right OCD where, you know, if things aren't put in a certain way, or if I don't touch certain things in a certain way, then something bad might happen. I've seen what we've kind of called me too OCD. So I mentioned OCD kind of follows kind of what's either hot, or sometimes you'll see things in
Right.
the press, or
Interesting.
these
Right.
were like,
Because you have to have the thought in order to have it be intrusive. You have to see it somewhere or be exposed to it,
yeah, I mean, we don't know, or it just makes it more likely that something you get stuck on, right? So I've
okay.
seen a couple men who are, you know, 10 years out of college, and it just so happened around this movement started having the thoughts of, what if I did something then, right? You know, situations that lots of people are in college, but what if I didn't perfectly get consent? Or what if I am one of those people? And
Right. Fat parties
we
and
could
all that.
argue that that's a good conversation and a good thought for us to all examine, right? Just in
Right.
society. But for these people, it took over. They couldn't function anymore. They kept thinking about it hours and hours and hours. They wanted to start calling girls that they had maybe made out with in college and double check for sure that they didn't do, right? Which is like, that gets kind of, you know, weird and intrusive. That's the crux of this with OCD, regardless of what the content is the person is trying to get certainty. They need to be 100% certain. And if there's a 1% chance that they're not sure, it takes over, and it really can destroy them in certain ways.
Is this a branch of OCD, these types of OCDs, where it's like more like a thought, like if your thought, not necessarily, it sounds less of a compulsion, honestly, like more of just, you know.
So the compulsions are all of the ways that they cope with that. So it's them sitting there for 2 hours trying to go over every time they made out with a girl to see if they did anything. I have a guy who is so scared that he could do something without remembering, or if he was at all out, you know, so if he didn't sleep well, maybe he'll be foggy and do something he's not sure of. He logs everything he does in the entire day into a book, literally every second, right? So that's, again, the difference of saying, oh man, did I do something, and kind of being anxious, versus this person has to log every minute of his day in a book. And if he loses track of it, he's in terror, because what if during that minute he forgot to track, he accidentally touched someone in an elevator, right?
Interesting.
It goes far past rational.
So that brings me back to the question before, of when you said that, oh, there's a difference between, like, everybody has intrusive thoughts, but then OCD is genetic. The OCD part, not everyone, like, you know, only some people have OCD genetics, but a lot of this, I don't know. I mean, even in my own situation, you know, it's like, well, when do you cross that, and how, and this is kind of like what we were talking about earlier too, right, with the DSM, is like when do you cross that, like when does it become like, oh, now it's OCD, or, you know, like, or I didn't stop it in time, so I guess now it's OCD. But does that mean that I was always genetically inclined to have OCD?
You're right. We don't know. I mean, it could be that you're on that spectrum, right? And that it takes something fairly significant and severe to really tip you over. I talk to people a lot that come in with things where I would say they're living pretty much the way they want, but they're a little uncomfortable. And we say, look, I don't know that I would say that you have OCD yet, but you know, maybe they're just starting to change some behaviors or be extra cautious with things. And I'd say, I don't think I'd say that you have just OCD yet, but we know that there is a spectrum, and we don't want you to tip over at some point into that. And if you keep doing this thing, if you keep avoiding this, you're going to grow into what could become OCD, right? Or you can start basically doing the approaches now where we say, let's not avoid, or let's try to work on living with uncertainty around whatever it is in general. And that might be the difference between fully developing OCD and not, right?
See, that part sounds like mind over matter, because that almost makes me feel like a lot of people with intrusive thoughts, like if you just indulge in the thought, you know, if you indulge in that thought and you avoid it or try to do things about it, then it becomes OCD if you do it for long enough. But if you choose not to indulge in thought, or choose to intervene, or choose to go to a hypnotherapy or a psychiatrist or whatever, or choose to meditate or whatever it is to get yourself out of it in time, then you just don't develop the OCD.
I guess,
I'm not saying in all cases. I mean, yeah.
The mind over matter thing, I guess I think about more, just because what it sometimes could, I guess, suggest is that,
right,
someone is sort of not trying hard enough or
Right.
something.
We don't want to suggest that. Yeah. Yeah. No, that's,
But
yeah.
with anxiety, right? So I do talk about with patients that, and there's a difference in severity. I have some OCD patients, the OCD is so severe that they ultimately need brain surgery, right? So that's obviously a different group of people than the ones that don't need that, right? And so there's clearly how much you can do will depend on how severe. But we talk about choice. So this is kind of maybe what you're saying is you can feel uncomfortable and you can feel uncertain and you can be really scared and really anxious and your heart can be racing. And I can't control your thoughts. I have no control over what thoughts pop into your head. We can help you have control over what behavior you choose, right? And is that a behavior that's in line with things you value and the kind of life you want to live? Or is that a behavior that's based on fear and avoidance? And that's kind of what you're getting at with mind over matter is we have a choice here. And if we continually choose something in line with our values, however uncomfortable it might be, over time we can change those fear circuits a bit, or we can override them, or we can kind of get out of the rut, right?
Right. And therapy does that as well, obviously. Yeah. Helping with
Totally.
changing the thought pattern. And so does, coming from a life coach, personal development perspective, that is like 90% of personal development or life coaching is like mindset shifts. You know, it's all focused on that. Like Tony Robbins, I think I saw this thing with Tony Robbins where he said that he doesn't even believe in depression. He said depression doesn't exist. And I remember watching something where he had this person go up on stage and she was very depressed. And she told him like how depressed she was and she was suicidal and she didn't want to live anymore. And he like switched her mindset and supposedly cured her within like 5 minutes of coaching her on stage. And it was a little bit of tough love and a little bit of mindset shift, and well, actually a lot of tough love. But I mean, of course, I don't think it's going to happen for everyone. And I have mixed feelings about that, I'm still trying to figure out, you know, especially being in my field and, you know, but I'm curious, what do you think about that? Have you ever watched Tony Robbins or gone to any of these?
I haven't, but I mean, I think you know, like what you're saying, I think severity makes a big difference. I think circumstance and privilege make a big difference, right? So it's easy to have a mind shift if you're pretty privileged and you have a lot of resources and you have time, right? But if you're a single working minority mom who is struggling to make ends meet, that mind shift can be a lot harder. And so I think that's worth thinking about. But I mentioned I practice from a framework called acceptance commitment therapy. It's one of the kind of like cognitive behavioral therapy that you've heard about.
What
ACT
is that?
or ACT. So it's the kind of, to boil it down really simply, the principles of what are your values and what are really important to you. Not your parents' values, not society's, but like what gives you the warm and fuzzies about life, sort of, right? And regardless of what you struggle with, how do we help you move in that direction, right? So you have behavioral choices you're going to make all day, throughout the day, every day. Are you moving towards your values or are you moving away? And for some people, they come in and they have no idea what their values are. For other people, they come in and the fear is so much that they haven't even been thinking about them. All they can think about is not feeling fear. And so for someone like that, some education, some tough love, some mind shifts, some convincing them, like helping them actually just sit there and center on values, that might be a huge shift for them that totally gets them on the right track. You know, for someone who can't touch a single thing in the environment because their OCD is so severe, you're going to need more than that, right?
Right. No, it sounds very much like the way I approach personal development and life coaching, which is, a lot of what you just said, acceptance commitment therapy, but acceptance and commitment is a lot of personal development as well, a lot of that. But and then of course there's a certain point where, like, you know, certain clients that I have, even I'm like, I would be happier if you got therapy and align with this, or, you know, instead of this, or do that first. So it really depends on the case by case basis. But that's something important, I think, something really grand that everyone should always keep in mind, which is acceptance and commitment. I love it. I actually want to do that therapy. You know, so personal developmental. It's like, accept what is it that people are accepting, like everything about themselves, right?
It's sort of being willing to accept certain feelings and certain maybe discomforts in the interest of committing to your values. I mean, that's the words actually put some people off and means like, oh, I have to accept that this is going to be here forever, this and that. But really it just means we'll use the term willing a lot. What are you willing to feel and willing to do in the order of kind of having the life you want, right?
Mm-hmm.
For some people, you know, and if CBT therapists would argue, because when the ones that do it really good, but like a simple way is sometimes in CBT, you'll see people say, rate your anxiety, you know, is it a 10 or an 8 or whatever? And we're going to do this thing and we're going to try to get your anxiety down to a 4, right? Mm-hmm. With ACT, you'd be more apt to say, okay, you know, what are your values? What behavior is towards or away from that? And regardless of where your anxiety is on that scale, are you willing to feel it so that we go do this? And we don't track that as closely. Now we know that if you start doing your values, oftentimes those numbers come down, but it's not the goal. You're okay. You're willing to have it there if it's going to be there. So it's kind of, it's different semantics and kind of different focus in a way. Good CBT therapists do both, but.
Right. It also reminds me of a mixture of the whole feel the fear and do it anyway. I don't know if you've ever read that book, very popular book, but there's like a whole school of thought with like, yeah, you feel the fear and you do it anyway. And then living with your discomfort, which a lot of people who have come on to our podcast actually talk about what's helped them. And one of the major things that they keep mentioning is living with discomfort, like being comfortable with being uncomfortable, which I find fascinating that so many people have mentioned it.
Uncertainty a lot, we'll use that term.
Okay, living with uncertainty.
Being okay, taking healthy risks, because everything you do, and certainly anything that's worth it, has some level of uncertainty and some level of risk, right?
Right.
Probably can't come up with anything really.
Right.
We're not saying go take a nap in the street. That's an unhealthy risk, right? But walking across the street is probably a healthy risk worth taking at times.
Right. And then we have the whole rhetorical, like, what is healthy, and what we could get so deep into that maybe for another podcast. I'd love to discuss about all these things. But I was just going to add that it also reminds me a little bit of the Eastern philosophy of we have to accept our sufferings and our discomfort. Like we have to fully accept ourselves and accept our situations and what's going on. You know, we have to do that first, like before anything. So yeah, it's in a lot of different Eastern philosophies. So yeah, it definitely reminds me of that.
Resignation, right? I think that's what some people think of. I'm resigned to this.
That's what some people even practice it that way, which you're right. I don't agree with that either, because I always say like whatever is empowering, and there's disempowering ways to go about these, you know, philosophies. Definitely. Yeah. If you resign to it and you're like, oh, this is just the way it is and this is as good as it's gonna get, that's you know, is it really empowering? Is exactly like what you said, you know, will it help you get to your true values? I'm just so curious, when you said some people with OCD have to get brain surgery, like what part of the brain do you know?
So there's a few different targets. So, you know, there's people put it at the cingulate gyrus, there's the subthalamic nucleus, I'll spare you some of the, you know, but there's different.
But what does it do? Yeah, like what does that specific?
So there's two main types of it. One is we can go in and just make a lesion. So we can kind of cut some of the fiber tracts. And for some people that will sort of release them from that cycle of being stuck. The other thing that is being looked at more so now is stimulators, where you can put in a sort of microchip, if you will, that stimulates, and that stimulation can break that cycle. And the benefits of the stimulator is we have all kinds of fancy controls that we can turn it on or turn it higher or change the shape of the field. We can do all this stuff that you just can't do if you just cut something. And it's also reversible if it's a stimulator, so you can turn it off or take it out or that kind of thing. And so for people with really, really severe symptoms where therapy and medications and maybe TMS or some of these other things haven't done the trick, the surgery can actually be a fairly successful option for quite a bit of those people.
Wow, fascinating.
Yeah,
it's so fascinating. I love it. Well, we are definitely out of time, Ryan. So it has been such a pleasure having you. I've really thoroughly enjoyed this conversation. Yeah, thank you so much, Ryan. Be safe there in Oakland, California.
Thank you. Yeah, have a good one.
Thank you. I'll see everyone later. Bye. Thanks for tuning in. Bye.